All right, guys, let's go ahead and get started. Today we are talking about how to manage hepatic encephalopathy. So really the most important thing is that hepatic encephalopathy, it's like credit card debt. So if you don't fix it early, then you will never fix it. So some definitions: hepatic encephalopathy is elevated serum ammonia. Ammonia is toxic to the brain. So this causes some of the symptoms that we'll talk about. When you're thinking about hepatic encephalopathy, what you need to do is you need to associate it with a trigger. So think about someone who already has cirrhosis and then something just triggers their body, similar to adrenal crisis. So we'll talk about some of the reasons, but the two biggest reasons will be infection and dehydration. And it's always good to make sure you're dealing with the right diagnosis. So that means you've ruled out DKA, you've ruled out just being drunk, you've ruled out some sort of toxic chemical ingestion, and you've ruled out uremia from like a UTI. So the whole issue in hepatic encephalopathy, if you're like me, you probably forgot this from years 1 and 2. So the whole point of the liver is to turn ammonia into urea. And if it can't do that, then ammonia backs up into the brain. And so that's where it causes most of its damage. The vignette is going to be a patient who suddenly doesn't know where they are and they're not responding well to questions. And if they're being nice, they'll give you the physical exam finding of asterixis. The big idea is it'll be fairly obvious, but they'll try to ask you some second and third order questions about hepatic encephalopathy. And so that's where we're headed. So some things that cause cirrhosis: alcohol, Wilson disease, alpha-1 alpha-trypsin deficiency, acute liver failure from drugs. Obviously, there's other things like maybe PBC or hepatitis. But really the big one is just an alcoholic. And so what I want you to do is I want you to think of hepatic encephalopathy as something that causes an insult to someone with pre-existing liver disease. So some of those scenarios would be dehydration, sepsis, hypokalemia, GI bleed, pneumonia, SBP, Budd-Chiari. Really the idea is that this is a long laundry list. And what you need to do is just identify that someone with pre-existing cirrhosis now has additional stress on the liver. That's the big idea. And so one second order question they like to ask is some of the acid-base changes. And so when you have ammonia in the brain, it causes this, you see this person just huffing and puffing. So it causes a respiratory alkalosis. This is the most common ABG problem in liver disease. And so what you want to think about is, you have ammonia elevating, and that causes the CNS to fire off its respiratory centers, and now you're losing CO2. So that's what causes this alkalosis. And when we talk about the management of hepatic encephalopathy, once you start getting into level 2, level 3, real clinical practice, you always need to think about, taking care of the whole patient. And so if you have someone that's entering respiratory distress, you need to think about if they're protecting their airway. And if they're not, you might have to intubate. You might be talking about, let's make sure they're not hyponatremic. Let's make sure they have enough potassium. Let's make sure that they don't also have uremic encephalopathy. Let's treat any AKI that exists. And so when you're out in the real world, it's not just a multiple choice question. You need to start thinking about every organ system. With that being said, on a test, the most important thing to do first is IV fluids. You need to make sure they're not just dehydrated. And then secondly, the thing you'll be asked about is lactulose. And what this does is it causes an acidic pH in the gut. And I've also seen this called non-absorbable sugars. So that's another thing, right? This is what the test writers have been doing, is they know that you know about lactulose, so they're going to find some way to just test it, and you won't have any idea what they're talking about. So you need to always think about synonyms. The mechanism of lactulose, pretend this is the GI tract. Lactulose becomes lactic acid, and lactic acid lowers the pH in the gut. And what that does is ammonia here becomes ammonium. And so this is the ion. And what we can do with the ion is we can excrete it. And so really the big idea is ammonia becomes ammonium. And some stupid ways they could write this is like, you know, production of acidic ion. Or, you know, just try to think about all the different things they could, all the different synonyms they could use. One real life thing is people hate taking lactulose. You'll prescribe lactulose, they will not take it because it causes explosive diarrhea. And so what if lactulose fails? What if they still are encephalopathic? And the second line treatment, which you'll be asked about, is rifaximin. And so this is an antibiotic that binds to RNA polymerase. The big idea is it kills off the bacteria that make ammonia. So what I want you to think about with these is they're called ammonia lowering therapy. And that's the big idea. So just recap, you know, we're going to do IV fluids, lactulose, and then rifaximin. And so what if this fails? What if rifaximin fails? Really what we're going to do then is do a TIPS procedure, see if that fixes it, see if, you know, the decreased portal pressure fixes some of their insults. But ultimately, they're headed to a liver transplant. And one thing I learned on my GI rotation is you never present a patient with cirrhosis without calculating their MELD score. And so you can see I went on MD Calc, and really what they care about is creatinine, bilirubin, sodium, and INR. And so the creatinine, the bilirubin, and the sodium, that'll be given to you in a CMP, but the INR, you have to specifically order it if you want it. And so I remember we had a patient who basically we couldn't calculate their MELD score because we hadn't ordered an INR and a ProTime. So that's just something to think about. That is the end of this video. Let me summarize it for you. So hepatic encephalopathy is caused by cirrhosis of the liver causing an ammonia buildup. This causes patients to become confused. They start flapping their hands. They don't know where they are. The most likely cause is alcoholic liver disease. You need to be thinking about any kind of insult that may have caused it. Hepatic encephalopathy causes respiratory alkalosis, and we treat with IV fluids and lactulose. If they failed medical therapy, they need a liver transplant. Thank you, guys.